Hello, I'm Lauren Henke, and I'm your co-host of the NRG Oncology podcast, along with my co-host, Stephen Chun. For those of you who haven't subscribed yet, remember to subscribe on Apple, YouTube, or Spotify. Today, we have a podcast focusing on one of the most common reasons we give radiation for cancer, which is bone metastases. When cancer spreads to the bone, these metastases are often painful and yet can be relieved by short courses of palliative radiation. Talking about bone metastases today is our guest, Dr. Erin Gillespie, who is principal investigator of one of our newest NRG-oncology trials, CC014 for bone metastases. She is a radiation oncologist at the Fred Hutchinson Cancer Center of the University of Washington in Seattle.
I've known Dr. Gillespie for over a decade since we were both residents in radiation oncology. She was a resident at the University of California, San Diego, and somehow I always knew she'd do great things. Before we get into the details of NRG-CC014, Dr. Gillespie, there are members of our audience who aren't radiation oncologists and not even physicians. In really simple terms, can you explain to our audience who might not have medical background why cancers spread to the bones and what is usually done about them? And just how common are bone metastases in cancer patients?
Thanks so much again for inviting me today. Dr. Chun, I really have always valued you as a collaborator, and I look up to you. So in general, metastatic disease means when cancer has moved from its primary origin, like an organ like the lung or the breast, and into other parts of the body. And the bones tend to be one of the most common places where cancer goes. It varies a little bit from one cancer to another, but the vast majority of patients with breast and prostate cancer, if they have metastatic disease, will have it in the bones. It's a little bit less in other cancers like lung cancer, but it's still just a very common occurrence. And what that means is generally when you're in the metastatic setting, the most common sort of treatment approach is systemic therapy. And those might be cancer-directed medications or agents that actually promote bone growth, like they slow the breakdown or encourage bone formation, like you might hear the word bone modifying agents. But sometimes these tumors grow so large in the bones that they can actually cause pain or other problems, like if they're near the spinal cord, or if they can actually make the bone so weak that it breaks or fractures. And that's when usually we're intervening with local treatments where, as opposed to a medication that goes throughout the whole body, we're talking about radiation, surgery, and sometimes other interventional radiology type of treatments. As you mentioned, our usual approach is to wait until pain occurs in order to intervene with radiation.
So, Erin, prior to joining the radiation oncology faculty at the University of Washington, I know that you were a member of the radiation oncology metastatic service at Memorial Sloan Kettering Cancer Center, where your team led a major multi-institutional randomized phase 2 trial of prophylactic radiation for high-risk bone metastases that was published in the Journal of Clinical Oncology. While you mentioned we usually wait or historically have waited for bone metastases to become painful or maybe even cause a fracture before we offer a local treatment, this study was unique in that it compared treating high-risk asymptomatic or bone metastases that weren't really causing problems that patients can feel up front with radiation versus waiting for them to become painful. Can you walk us through that study and what it found?
Yeah, so this was like you said, it was a phase 2 trial, which means sort of a smaller, earlier phase study, where we enrolled patients that didn't have pain, but they had bone metastases in what we estimated to be areas at high risk for these skeletal events, which are fractures, cord compressions, etc. We randomized them to usual care, meaning half the patients went on to receive the standard approach that you would normally, and the other half got early radiation. And we found that this early radiation approach reduced the subsequent event, like skeletal related events, even when you removed radiation for pain as one of those events. It's sort of a complex endpoint, which I'll explain a little bit later. But we also found, differences in hospitalizations, and subsequent pain experienced by patients was better by doing early radiation, but we did not see a difference in overall quality of life.
I remember reading your phase 2 study a couple of years ago in the Journal of Clinical Oncology, and I was really impressed that with fairly small numbers of patients, you showed not only a reduction in skeletal events that you've talked about, but what appeared to be a reduction in hospitalizations and even a possible survival benefit. With so many benefits seen in this study, I remember reading the conclusion of your manuscript, and I encourage everyone listening to read it because it's actually fairly short and well written. You conclude that a confirmatory phase 3 randomized trial is needed, which is exactly what CC014 is. So, with results that were so good from your previous work, can you walk us through why exactly we need a larger confirmatory phase 3 clinical trial to confirm that delivering prophylactic radiation is benefiting these patients?
Yeah, exactly. Notice I didn't even mention overall survival in my initial discussion, Steve, because, that was really a surprising finding for us. I do think that, I mean, it's a very small study, and we've seen time and again that small studies, when replicated, don't necessarily, we don't know if that was based on the intervention or something else. I do think that it gained a lot of interest and probably fast-tracked this concept to, getting to this confirmatory, larger, multi-center phase 3 opportunity, and is important to know if this is really extending people's lives. So interestingly, in designing the phase 3 trial, when we talked to oncologists, we did a survey. We asked them what would be meaningful endpoints for their practice change. And honestly, overall survival is not necessarily required. Like in the metastatic setting, palliative endpoints, very patient-oriented endpoints that don't necessarily prolong life, but make life better are still very important. And this idea that skeletal events or these fractures, core compressions, things that land people in the hospital is still very important. And confirming that is kind of the primary goal of this next study. But we're fortunate enough that we'll be able to power for a secondary endpoint, which just means the study will be large enough for overall survival to be the question to be answered to some extent. The other really critical piece is that we don't really know who should get early radiation. In reality, only about 1 in 10 patients on that original trial that didn't get early treatment experienced a subsequent fracture or cord compression or surgery or hospitalization as well, was about 10%. So that means that like 90% of people could easily be treated without ever needing to have been treated, which is a lot, particularly when you think about the number of patients with bone metastases, the number of bone metastases within a certain patient. And so I think there's a real chance to overtreat patients based on what limited we know from that initial study, and really has also motivated getting, more experience treating these types of lesions and understanding where is the benefit of doing this early treatment.
So, with this in mind, can you walk us through CC014? Who's eligible? What's the design ultimately? And if patients are selected for prophylactic radiation, what kind of radiation techniques and doses are allowed? Are there any meaningful ways the CC014 protocol departs from your prior phase 2 trial?
So eligible patients have widely metastatic, meaning this is not an oligometastatic trial where they have more than 5 locations of metastatic disease. They have to have solid tumors, meaning it's not sort of hematologic malignancies, but things like breast cancer, prostate cancer, lung cancer, colorectal cancer. And they have to have at least 1 bone metastasis in what's deemed a high risk location, which generally is certain levels of the spine, the hip area, and certain long bones that may be at increased risk of fracture, theoretically. And so patients with meeting those criteria would then be randomized, again, 1-to-1, half of them receiving early radiation for something that is not causing them problems currently or usual care. The randomization is stratified by histology and bone modifying agents. So far, everything I've said is the same as it was on our phase 2. The addition of bone modifying agents as a stratification variable is new. As I mentioned in the beginning, bone modifying agents are systemic therapies that can help reduce fractures and improve bone health. they're recommended in all patients with bone mets, except for maybe those with a certain type of prostate cancer, but they're not always available or used. And so we found about half of patients were on them in our original study, which was balanced, fortunately. But it was very important that since these can impact skeletal events, that was included. And then once patients are randomized and treated, they're followed for up to 2 years. And the primary endpoint being the skeletal events. The difference from the phase 2 being that, I mentioned it's sort of a composite endpoint where radiation for pain is actually one of the criteria for a skeletal event. And since that, is kind of complicated when your treatment is early radiation, we removed that from the primary endpoint of this trial. And then the other thing that we mostly collect the similar outcomes, pain, quality of life, although we've pre-specified an analysis of some of the quality of life dimensions that would help evaluate like potential mechanisms of improvement based on functional status to better understand how radiation is impacting patients.
So I know that we've talked a lot about some of these technical terms pertaining to skeletal events, high risk bone metastases, etc. But for people out there who aren't in the medical field, I want to use some of my experience from outside of radiation oncology to put this into perspective. I actually did an internship in general surgery before radiation oncology. And for someone with a high risk asymptomatic or minimally symptomatic situation, we always seem to have better outcomes than intervening in an emergency. For example, if someone has a bad hernia that we were really worried could strangulate or cut off circulation to the bowel, having a well planned out surgery to fix it with adequate preparation in a controlled environment always seemed to turn out better than doing this in the middle of the night, completely unprepared in the operating room in an emergency situation. I like to think of what CC014 is doing as trying to pull people back from going over the cliff or having that bad fracture of the hip or fracture of the spine or something, rather than letting them actually fall off of that cliff. Do these analogies capture, in a nutshell, what you're trying to accomplish with CC014 by comparing prophylactic radiation with waiting for a big problem happening, like someone going off of the cliff and breaking a bone?
Yeah, I think you're absolutely right. And honestly, you explained that probably better than I've explained it myself in terms of really thinking about how can we do this early. I think the ways in which early treatment are potentially helping people and kind of where this idea came from was avoiding people going to the hospital for pain that is so bad that they need treatment. And we know that going to the hospital is a big undertaking and something we should avoid at all costs. But even just the development of pain, that may itself be, problematic. So trying to figure out who to treat before these events happen can benefit patients, but it can also help in the clinical flow. I think we end up doing urgent treatments with short turnarounds, and we may just have better outcomes by having a little bit more time. It would certainly help clinical workflows. And even hospitals, doing radiation when a patient is in the hospital is complicated for a number of reasons. So if we can actually see these people in an outpatient setting and sort of get things scheduled in a more, non-urgent way, I think that probably benefits patients, clinicians, and hospitals. But, it depends a lot on our ability to accurately predict who's going to have these issues, which is sort of to my point earlier that we really need more information on who we should be treating this way.
So logistically speaking, CC014 launched in early 2025. Can you talk to us about the logistics, how many patients you're looking to enroll over what time period? How's the progress been so far? And are there any lessons from your prior phase 2 trial that can help investigators facilitate enrollment?
So it's 280 patients over 2 years is the goal for enrollment. It was activated in mid-April, and I'm already receiving lots of emails around, centers that are actively screening patients. Some centers, have gotten this open very quickly, which is awesome. To answer your earlier question, I realized I didn't answer one of the, logistics is around radiation doses and techniques. And this is made to be pragmatic in that we allow 3 different radiation doses and techniques, which were all allowed on the phase 2 trial. The technical terms would be 8 gray in 1 single fraction, 27 gray in 3 stereotactic or higher dose radiation, and then a 20 gray in 5, which is sort of in between. We don't allow longer treatments than 5 treatments, in large part because this is a preventive setting, and we don't want people sort of coming into the clinic more times than is truly necessary. And then to your point about like what we learned from an enrollment perspective from the original trial, certainly following patients that were treated for symptomatic metastases is something that is highly variable in routine practice. And that's an important way that a lot of patients were identified. So, you get the patient referred with bone mets, they have one that's painful. You might at that time notice, oh, well, there's this other one in the left hip, which is not causing pain, and maybe we should treat that, or maybe we should consider enrolling that to the trial. You could either enroll them that day, or you could see them in follow-up and enroll them at that time. But this idea that, as radiation oncologists, patients are generally have to be sent to us for other issues, which has led to another kind of question, which is like, does this trial generalized to patients in the medical oncology clinics that really don't have symptoms or are not referred to radiation for other reasons? And so working with medical oncology colleagues, even radiologists, to help generate ways to flag patients that are undergoing routine imaging in medical oncology with metastatic disease undergoing routine imaging. Flagging those patients that might be eligible for the trial could be a really great way to identify patients that would have otherwise never been referred to radiation oncology.
The next question I wanted to ask you, I want you to speak to the new and junior investigators out there. It's hard to believe that you and I are no longer new or junior investigators, and it's been about a decade since we both completed residency training in radiation oncology. Since then, you have completed a randomized phase 2 trial, and you are now leading a national phase 3 randomized clinical trial. Could you speak to our junior investigators out there? What have been your biggest motivators? And what kind of advice do you give these new and junior investigators who I think already look up to you about clinical research and getting involved with NRG oncology?
I think really over time, a unifying theme for me has just been being motivated by the science and the questions that we're asking, and really getting to really the ground truth on questions that impact patients and patient outcomes and their experience of cancer care. My clinical practice is actually primarily treating breast cancer, where we have the luxury of a lot of high-level evidence and trials to answer so many clinical questions in routine practice. And I think that that's immensely gratifying and helpful to patients to be able to provide information and really like hard evidence behind the recommendations that we make. I think that there's a lot of room for more information in the metastatic setting. And, the other side of my, motivation is that my research, I originally was interested in sort of variation and quality, and a lot of the work has focused on health services and implementation science, where I've noticed that, we can sort of think that something will work and hypothesize. But when you actually run studies, it doesn't always work out. I think there's a big element in behavioral medicine where things often don't work that we assume they will. And so it's just been kind of a reminder that the importance of well-designed studies with really adequate control or comparison groups can help you get more to that ground truth. And so it's kind of moved me into more prospective interventional studies to really understand, like, not only is there variation in quality and types of treatments, but how do we, run high quality studies that answer these questions in a way that's also like generalizable to all of our patients, so that when we're in clinic, we can kind of answer these questions. I guess around that, I think a lot of it is just like pursuing questions and research that inherently motivates you, because research is really hard and there's roadblocks and rejections at every corner. And so, sometimes if you find yourself like working outside of a normal work hours, I think in order to really do that, you've got to want to do it. You've got to be inherently like interested in what you're doing for whatever reason. And then finding mentors that will support you through a lot of the rejection and the adversity is really critical, and reminding you that like this is just a normal part of the process, and not kind of quit. And I think that getting involved in NRG, I think it's a great opportunity. It's a great meeting. It's small. It's every twice a year, and so really starting to get to know the people within cancer types that you treat. I think it's a really cool meeting. It's really scientifically oriented, and you're hearing about studies at all phases of development and execution. And so start by kind of like finding what is your interest, and participating in those committees, I guess, would be my one thought.
I think that's just really nice advice, that perseverance and finding sponsors and mentors and pursuing things that you care the most about. So as with any NRG oncology trial, it takes a village or town or army or whatever they say to build it. Before we finish up, I want to make sure that we also give you a chance to recognize the people who helped you to make CC014 happen.
Totally. The NRG Cancer Prevention and Control CPC committee is really the one that navigated this. Lisa Kachnik, certainly as one of the leaders, has been huge, but also Erica Field, administrative, and Danielle and Sarah, and there is a whole team that has helped really navigate this for it's been about 2 years since we started this conversation through all the approvals. So that is its own team, but and there's an endless number of other people, but I'll just highlight certainly like Jonathan Yang, the director of the metastatic service at MSK when I was there, and really the first and foremost person in getting this specific project from its initial phase 2 concept through to where it is today, and continuing to serve as the co-PI on this phase 3, even though he and I are pretty close in, he's only a couple years older than me, but like had done a lot more therapeutic trials than I had, and just an amazing collaborator and peer mentor almost. And then, Rupesh Katesha is just a key person on the trial. I met him through the MSK Alliance. Oren Kalin gave me a leadership role to oversee research in that affiliated network, and I got to meet Rupesh and really understand like a little bit more of a community-based, the challenges and benefits in research, clinical research and trials. But he's just such an amazing collaborator, always available, always, gives high quality care to his patients, super productive. And then Max Van Rub was our, critical insights from a multidisciplinary perspective. And then at the end of the day, like I have to mention sort of just leadership support. I mentioned Oren as sort of an early advocate, but the funding for the phase 2 trial, that really, what I learned from the NCI review process was like what has worked before, and what has, the precedent that you set in your preliminary data is just so critical for designing your next phase. And so when I finished that process, I emailed Simon Powell and was like, the chair at MSK at the time, I was like, it is just so important that like institutional leaders like support these early phase preliminary studies with pilot funding and support, particularly for junior investigators, to really move concepts. And I think that department did contribute a number of different concepts in the metastatic space in a short period of time. So being mindful of those things are probably, but yeah, like I said, there's a lot of people, and I'm just lucky to have gotten involved.
Today, we had Dr. Erin Gillespie, the National Principal Investigator of NRG Oncology CC014, which is comparing prophylactic irradiation with observation for patients with high risk bone metastases. Dr. Gillespie, thank you for joining us today, and I want to wish you the best of luck on CC014.
Yeah, no, thank you so much for having me. And, please encourage your listeners to reach out with any questions about the study. We're happy to move it forward and look forward to next steps.
The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.